Hello again. This is a chest x-ray on a 60-year-old female patient. The finding that we'll discuss today is a common finding in practice. Despite of that, there are some concepts that are confusing. Both seniors and juniors alike sometimes struggle with understanding the concepts of this finding, and that's why we'll try to simplify it today. Your first impression is enlargement of the cardiopericardial silhouette. However, when you look carefully, you'll notice that this enlargement is actually a superimposed opacity that has different densities. The abnormality has a well-defined border and has a level that separates air from fluid, so there is a fluid level. When a fluid level is seen within the lung, you think about an abscess. If it's seen within the pleura, you'll think about empyema, but if it's in the mediastinum, it's something else. So this represents a bowel within the mediastinum containing air and fluid, and this is actually the stomach. The X-ray tells us that this is a hiatus hernia containing most or part of the stomach. Now, before we go to the CT on that abnormal case, let's look at this normal case to understand some basic gastric anatomy. For the sake of orientation, you're looking at a coronal CT where this is superior, this is inferior, this is right, and this is left. Above the diaphragm, you see the lungs and the heart with the mediastinal structures. Below the diaphragm, you see the bowel loops, liver, and spleen. The stomach is below the diaphragm, particularly to the left side. This is a CT scan where the patient received intravenous contrast, that's why the vessels are bright, and oral contrast, that's why the bowels are bright as well. Now let's follow the stomach, starting from the esophagus. This here is the esophagus, going all the way down. So the esophagus descends through the esophageal hiatus of the diaphragm and meets the stomach at the gastroesophageal junction. So here you see the gastroesophageal junction, which is below the diaphragm. Now continuing the anatomy, this is the stomach. The part of the stomach that's high here abutting the left hemidiaphragm is called the fundus. As we scroll back and forth, you notice that the fundus opens into a larger part that contains air and contrast. And this larger part of the stomach, it appears dark here because air goes anteriorly, is called the gastric body. So again, if you go from anterior to posterior, you have air anteriorly, and posteriorly you're going to have contrast because the patient is lying supine. The gastric body opens distally into a portion that's known as the gastric antrum, which distally opens into a final, narrower, and muscular area called the pylorus. And this pylorus here opens into the first part of the duodenum. This left convex border of the stomach, the larger border to the left, is called the greater curvature. As you scroll back and forth, you notice that there is a smaller right-sided concave curvature. This is known as the lesser curvature. So landmarks to remember for the sake of discussion, you have the greater curvature, the lesser curvature, the fundus above, and the pylorus and antrum below. One more piece of information to understand before going to the abnormal case. And that's about the axis of the stomach. You have a long axis and a short axis. If the stomach looks like this, the long axis is an oblique axis from the fundus to the antrum from above below. On the other hand, the short axis would look something like this. So if the stomach twists along the long axis, left becomes right and right becomes left. Kind of a side-by-side rotation where the greater curvature may be on the right and the lesser curvature may be on the left. And this is what's known as organoaxial rotation. Now, if the stomach twists along the short axis, it's going to be an upside-down stomach. In that case, the fundus would be down and the pyloric antrum would be up, and that's known as mesenteroaxial rotation. Another fact before we go to the abnormal case is to emphasize that the gastroesophageal junction is below the diaphragm. If the diaphragmatic hiatus becomes wide, the gastroesophageal junction or stomach may herniate through that, and that's a hiatus hernia. There are two main types of hiatus hernia, a sliding hiatus hernia versus a paraesophageal hernia. The way more common type is the sliding hernia, where both the gastroesophageal junction and the proximal stomach slide above through the hiatus. In about 10% of cases, you may face the less common type, which is the paraesophageal hernia. It's sometimes confusing when you try to read about paraesophageal hernias in books. There are different imaging and surgical classifications out there, but let's simplify this. A type of paraesophageal hernia is when the gastroesophageal junction is in place, however, the proximal stomach goes above. The gastroesophageal junction does not herniate while part of the stomach herniates. A more advanced paraesophageal hernia is where everything goes above, the gastroesophageal junction and the stomach, or most of it. This type of paraesophageal hernia is simply and nicely called an intrathoracic stomach, since the stomach is in the chest and not the abdomen. Now that we agree on the normal anatomy and we know the various types of hiatus hernias, let's go to the abnormal case. Remember the x-ray on the abnormal case where you had most of the stomach seen above the diaphragm on the chest x-ray? This is the correlative CT scan on that patient. It's done without intravenous or IV contrast. You'll notice that the stomach is not in its normal location below the left hemidiaphragm. The entire stomach is herniating through the esophageal opening in the diaphragm and goes all the way up within the chest. So this type of hernia is the paraesophageal hernia, where you have everything within the chest, which we called an intrathoracic stomach. Let's try to follow the esophagus and stomach on this scan. This is anterior, this is posterior, here's right, and here's left. This is the esophagus within the mediastinum, and we're going from above below. Then the esophagus goes all the way here to join the stomach at the gastroesophageal junction. This is the entire stomach within the lower hemithorax. And here's the distal stomach as it connects to the duodenum. Now, which type of rotation has occurred within the stomach? Is it an organo or mesenteroaxial one? You'll notice that the greater curvature remains on the left while the lesser curvature remains on the right. So this is not a side-by-side rotation. The stomach is not rotating along the long axis or the organoaxial type. You'll also notice that the esophageal hiatus is almost at the same level or even lower than the distal stomach, where part of the gastric fundus has shifted a little bit inferiorly. So that's a hint of things being upside down. Remember, if what's up is down and what's down is up, that goes with rotation along the short axis. And that's what we called a mesenteroaxial rotation. All types of hiatus hernias are associated with gastroesophageal reflux, but paraesophageal hernias are more dangerous, since they have a risk of twisting and leading to a closed loop obstruction. And such a closed loop obstruction may strangulate the blood supply to the stomach and lead to gastric ischemia and necrosis. That's very serious. Now, with this case, you don't see any feature that suggests obstruction, since the proximal esophagus is not really dilated. There are no fluid collections or fat mesenteric stranding within the mediastinum or upper abdomen. And most importantly, the patient was relatively asymptomatic, apart from reflux. If the gastric rotation is leading to obstruction, that's when you use the term volvulus. So be very careful when you throw that term in the report, since the surgeon would take that as an obstruction. This is a very common mistake that we see in reports, throwing the term volvulus to replace the term rotation in a patient who has no obstruction. So for radiology residents, be very careful. Don't throw the term volvulus unless you see a real obstruction. On the other side, for surgeons and clinicians, if you see that term gastric volvulus in the report, please discuss the case and make sure that's used correctly, especially that the term may be mistakenly used in a report and you have a patient that looks relatively well in front of you, so use that advantage. This is a noisy coronal image on the same patient to show you the abnormalities. Here's the esophagus. The esophagus goes all the way down. It does not cross the esophageal hiatus. It's entirely above the diaphragm. It joins the stomach at an inferior location relative to the rest of the distal stomach. This confirms that the stomach has flipped along its short axis, a mesentero-axial rotation. Let's continue with the stomach. You have the gastric body all the way to the antrum, which then goes all the way down again to meet the duodenum. So the final diagnosis here is an intrathoracic paraesophageal hiatus hernia, which is mesentero-axially rotated without volvulus. Let's summarize what we learned from this case. First, a fluid level is usually not normal, and if it's in the mediastinum, think about a hiatus hernia. Second, know your gastric anatomy, gastroesophageal junction, fundus, body, antrum, and pylorus. Third, remember that the greater curvature is on the left, the lesser curvature is on the right, the fundus is high, and the antrum is low. There are two types of hiatus hernia, the common sliding hernia and the less common and relatively more dangerous paraesophageal hernia. With a sliding hernia, both the gastroesophageal junction and part of the stomach slide above the diaphragm. With paraesophageal hernia, the gastroesophageal junction is in place and part of the stomach ascends above the diaphragm, or the entire stomach is above the diaphragm. If the stomach flips from side to side along the long axis, this is called organoaxial rotation. If the stomach flips upside down along the short axis, this is called mesentero-axial rotation. Very importantly, you have to address for clinical signs or imaging features of obstruction, meaning volvulus. A paraesophageal hernia with gastric volvulus is a closed loop obstruction that may lead to strangulation and ischemia, so that's very serious. However, on the other hand, gastric rotation does not equal volvulus in all cases, so be very careful when you use that term. Use volvulus when you want to denote obstruction. If there is no obstruction, just say rotation. Thanks for watching. Your comments are appreciated as usual, and let's see you with more cases next week. Hello everybody, this is a quick case that is dedicated for seniors. Juniors, you might get something out of it as well. The reason I chose this case is to deliver a quick teaching point to discuss a misconcept that we commonly see in reports. Now this is a high-resolution chest CT on an elderly patient with lots of lung changes. Without going into much details, such details would be discussed in other cases. The patient has a bilateral, peripheral, and basilar predominant pattern. This pattern is a mix of interstitial lung disease, namely fibrosis, with superimposed ground glass opacities. Now we agree that we have a bilateral, peripheral, and basilar predominant fibrotic disease. My teaching point is actually about the soft tissue, not the lung windows. So let's look at the soft tissue windows together. This is a study without contrast, and on the soft tissue you see these rounded foci of high density, consistent with calcifications. And as you look further, you'll see more of those calcific foci bilaterally. Now, there is a differential diagnosis for small calcific foci within the lung. The commonest would be a granuloma. And the most common, universally accepted reason for granuloma is prior infection, in particular prior tuberculosis. Other infections can do that, such as the fungus histoplasmosis, and there are other non-infectious reasons could lead to this as well. Now back to the important point. In many cases, this would be reported as a calcified granuloma, and the implication of that in endemic areas may mean that this patient has old TB or latent TB. Although latent TB is common, it's not active TB. Just putting that in the report might have some implications. And here comes the potential misconcept. These calcific foci are most likely not granulomas. Usually when you see granulomas due to old TB, they're either scattered or upper lung. For these high-density foci to be numerous, bilateral, and in the same distribution of the fibrosis is unusual. Add to that, you don't see random calcified granulomas in the areas that are not involved by fibrosis. So basically, the distribution of these calcified foci within the fibrotic lung is extremely unusual, and for it to spare the non-involved lung is also unusual. So what are those foci? Given their distribution and the numerous number within the involved lung, these are ossifications. Pathologically speaking, the difference between a granuloma and ossification is that ossification is real bone. If you resect this area here out of the lung, the pathologist would tell you that this has a cortex and a marrow, exactly like normal bone. This is in comparison to a granuloma, which is just a collection of abnormal calcium within an unusual location. So what we called here pulmonary ossification could be idiopathic or primary, and could be secondary to an insult. What we're looking at here is a secondary type, and that's related to a long-standing insult, which is fibrosis in this case. So if you see what seems to be ossification, this tells you two things. First, this is not a granuloma, and it might not mean previous TB infection. Second, like in this case, it tells you that there is a long-standing insult, and this is another feature that confirms the fibrosis here. To summarize, if you see calcific foci within fibrosis, think about pulmonary ossification. And remember, this tells you that this is real bone from a long-standing process, and it's not old infection from tuberculosis. By that, I end this case. Thanks for watching, and see you with more cases later.